Every 66 seconds, another person over 60 in this country receives a dementia diagnosis. By the time this video ends, dozens more families will have sat in a doctor's office and heard those words. And for a number that would genuinely shock most people, age was never the true cause of what happened to their thinking and their memory. The cause was sitting in a prescription bottle on their nightstand, the one their doctor signed off on and their pharmacist filled without a word of warning about what it was quietly doing inside their brain. What the research that has been building over the past decade keeps confirming is this. Specific classes of medications, many of them prescribed routinely to adults over 60 for entirely ordinary, entirely reasonable health complaints, carry a documented risk of cognitive decline that most patients are never told about. Not as a rare side effect buried in the fine print of a medication guide, as a real, measurable, and in many cases reversible risk that shows up across large, rigorous studies following tens of thousands of patients over years. Today, I am counting down the 5 medications most closely linked to memory loss after 60, from the ones that tend to fly furthest under the radar to the one I consider the single most important for this audience to understand. And I want to tell you right now that the reason I placed the final entry at number 1 has nothing to do with one single drug. It has to do with a pattern that may be the most common and least discussed driver of medication-related cognitive decline in older adults. And understanding it could genuinely change how you approach every conversation you have with your doctor from this point forward. Watch for it. Before we begin, drop your age in the comments and tell me how many prescription medications you are currently taking every day. I read every comment on this channel, and the picture those numbers give me shapes what I cover next. Now let us get into the countdown. Number 5 is a medication that sits in nearly every medicine cabinet in America and that most people have been taking for years without ever questioning because it does not require a prescription and because it has been marketed as one of the gentler sleep and allergy remedies available. Number 5 is diphenhydramine, sold under the brand name Benadryl and also hidden inside dozens of over-the-counter products labeled PM, nighttime, or simply sleep, from Tylenol PM to Zizazquil to many generic store brands. The little pink pill that costs $3 requires no doctor's visit and is treated by millions of older adults as completely harmless because the pharmacy keeps it on the open shelf. Inside your brain, it is anything but harmless. Diphenhydramine belongs to a class of drugs called anticholinergics. The term is a long one for a straightforward concept. These medications block a brain chemical called acetylcholine, which is the primary messenger your brain uses to lay down new memories, to sustain attention, and to keep the cognitive machinery running efficiently through the day. Acetylcholine is also the chemical that the brain produces less of as we age, which means that by the time you are in your 60s and 70s, your brain is already leaning harder on whatever supply remains. A medication that blocks it hits an older brain with far more force than it hits a younger one, for the simple reason that there is less cushion to absorb the impact. The structure that takes the hardest hit is the hippocampus, the small seahorse-shaped region tucked deep in the brain where new memories are formed before being organized and stored. When acetylcholine signaling to the hippocampus is repeatedly disrupted, the process of forming new memories becomes measurably less efficient. In my own practice, I have had patients who were taking a nightly antihistamine for years, who came to me describing what they called cotton wool thinking, a feeling of mental fog that had crept in so gradually they had trouble identifying when it started. Almost none of them had ever considered the possibility that the pink pill beside their bed was contributing to it. The research here is specific and sobering. Studies tracking older adults who use anticholinergic drugs like diphenhydramine regularly, meaning several times a week or more, have found meaningfully higher rates of cognitive decline and dementia diagnosis compared with adults who avoid these medications. The risk is not small, and it is not theoretical. It is documented across multiple independent research groups studying large populations over years. Here is what to do with this information. Look at the label on anything you take to help you sleep and anything marked PM, nighttime, or allergy formula. If diphenhydramine is the active ingredient, that is worth a conversation with your doctor. For allergies, newer antihistamines like loratadine, sold as Claritin, do not cross the blood-brain barrier the way Benadryl does and are considerably safer for your memory and cognition over the long term. For sleep, melatonin at a low dose, consistent sleep and wake times, and in some cases a referral to a sleep specialist are all worth exploring as alternatives. Never stop any medication abruptly without your doctor's involvement, but do stop assuming that over-the-counter means safe for your brain. I want to give you a picture of what this looks like in a real person, because I think statistics become more meaningful when they attach to someone you can imagine. Think of a woman in her early 70s, someone who has always been sharp, always been socially engaged, always been the one in the family who remembered every birthday and every anniversary without writing them down. She starts taking a nightly over-the-counter sleep aid because her sleep has become lighter and she wakes more easily than she used to, which is itself a completely normal change after 60. The pink pill helps her drift off, and she keeps using it because it works. Over the course of a year, 2 years, 3 years, the people around her begin to notice small things. She struggles to find a word she clearly knows. She loses track of a story she was telling. She misplaces things more often than before. Everyone agrees it is simply getting older. Nobody looks at the little pill beside the bed. That is the story I have watched play out more times than I would like to count, and it is one that in many cases could have gone differently if the right question had been asked at the right time. Number 4 is prescribed for a problem that most people feel too embarrassed to bring up at their doctor's appointment, and it works so well for the immediate problem that the cognitive price it extracts quietly in the background is almost never noticed or discussed. Number 4 is oxybutynin, sold under the brand name Ditropan, and a handful of others prescribed to seniors managing overactive bladder, the kind of sudden, urgent need to reach a bathroom that can genuinely take over a person's day and limit what they are willing to do and where they are willing to go. The relief oxybutynin provides is real, the embarrassment it spares people is real, and the cognitive risk it carries is also real, documented, and almost never mentioned at the appointment where it is prescribed. Oxybutynin works by blocking acetylcholine throughout the body to relax the bladder muscle that was contracting too urgently. But the same mechanism that quiets the bladder also reaches the brain, where it blocks the acetylcholine that memory and learning depend on. And oxybutynin in particular crosses into the brain very readily, lodging in the exact regions where the memory system is most sensitive to disruption. A landmark study published in the British Medical Journal followed adults over 65 who took strong anticholinergic medications, including oxybutynin, for more than a year. Their risk of developing dementia over the following years climbed by nearly 50% compared with people not on these medications, 49% higher. That is close to 1 in 2 from a medication prescribed for a condition most people never imagined could affect their brain. And in the overwhelming majority of cases, none of those patients were ever warned. They were told a pill would settle the bladder. Nobody mentioned it might also be eroding the neural pathways where their memories live. The fog in these patients, when it appears, gets attributed to age. People describe forgetting where they placed their keys multiple times a day, losing track of a simple conversation halfway through, missing an appointment they were certain they had remembered. Everyone around them nods sympathetically and says what almost everyone says, that these things happen when you get older. Nobody thinks to look at the oxybutynin prescription that has been on the monthly medication list for 3 years. The encouraging news is that you do not have to choose between your bladder and your brain. Newer medications for overactive bladder work through a completely different mechanism. Mirabegron, sold as Mirbatric, manages bladder urgency without blocking acetylcholine at all, and for most older adults produces similar symptomatic relief with a dramatically lower cognitive risk profile. Pelvic floor physiotherapy, which is more effective than most people expect and far more available than it used to be, also addresses overactive bladder without any medication risk whatsoever. Bring the question of alternatives up directly with your prescribing doctor. If they are not aware of the anticholinergic risk profile of oxybutynin in older adults, that is itself a useful piece of information. There is one more thing worth saying clearly about oxybutynin specifically. Because bladder problems tend to carry social shame that many older adults find difficult to discuss openly, people who are experiencing cognitive side effects from this medication are also often reluctant to raise either issue with their doctor. They do not want to acknowledge the bladder problem in detail, and they do not want to seem like they are overreacting to cognitive changes that everyone around them is already attributing to age. The result is that both problems continue silently when both could be addressed. If this description fits someone you love or fits your own situation, the combination of bladder urgency and cognitive changes that developed or worsened around the same time a bladder medication was started is a specific and important pattern to bring to your doctor's attention directly. Number 3 is the entry I want you to pay the closest attention to, because it is prescribed to millions of older adults for something that sounds completely innocuous, something that sounds like it could only help rather than harm. and it carries a hidden cognitive risk that the research has been documenting clearly for several years, while the message has been reaching the people who actually need to hear it far too slowly. Number 3 is paroxetine, sold under the brand name Paxil. Paroxetine is an antidepressant, and on the surface it appears to be a modern, gentle option. It belongs to the class called SSRIs, selective serotonin reuptake inhibitors, which are generally considered a safer and more cognitively friendly class of antidepressants than the older alternatives. This is true of most SSRIs. It is not true of paroxetine. Paroxetine is the one member of the SSRI family with significant anticholinergic activity, meaning it blocks acetylcholine in the brain alongside its effect on serotonin. That single characteristic separates it from related medications like sertraline, sold as Zoloft, and escitalopram, sold as Lexapro, which do not carry anything close to the same anticholinergic burden. The research on paroxetine and cognitive function in older adults is specific enough to be striking. Studies examining older adults taking different antidepressants have found that paroxetine users show measurable drops in short-term memory, word recall, and sustained attention within the first year of use at rates significantly higher than those seen with other antidepressants. The same mechanism that makes it effective for depression and anxiety, its potent effect on multiple neurotransmitter systems simultaneously, is also what produces the cognitive cost over extended use. The bitter irony in this for older adults is a real one. Paroxetine is prescribed to stabilize and protect the mind. In the longer term, in a brain over 60 that is already producing less acetylcholine than it did at 40, the medication can chip away at the very clarity and cognitive sharpness it was meant to help restore. Patients describe a kind of mental slowing, a difficulty finding words that used to come easily, a growing effort required to follow complex conversations or to hold a line of thought to its end. And in almost every case, neither they nor their doctor connect that experience to the antidepressant they have been taking faithfully every morning. The American Geriatric Society's Beers criteria, which is the formal professional guidance on medications considered potentially inappropriate for older adults, lists paroxetine specifically for precisely these reasons. It is a medication that the relevant professional body has formally identified as one to avoid in adults over 60 when safer alternatives are available. If you currently take paroxetine and you have been noticing cognitive changes since starting it, that is a conversation worth having with your doctor soon. Safer alternatives within the same drug class, including sertraline and escitalopram, provide equivalent or better outcomes for depression and anxiety in older adults without the anticholinergic cognitive cost. The switch is often straightforward and medically managed, and the cognitive improvement that some patients experience after a carefully supervised transition away from paroxetine can be dramatic. Never adjust or stop an antidepressant on your own, but do not stay on one that may be compromising your brain when alternatives exist that your doctor may not have specifically considered from this angle. One practical observation that I think is worth sharing here. Because paroxetine is an antidepressant, and because one of the symptoms of depression is difficulty with concentration and memory, the cognitive changes it can produce in older adults are particularly easy to misattribute. The person, their family, and sometimes their doctor assume that the cognitive symptoms are part of the depression being treated rather than a side effect of the treatment itself. This circularity can keep someone on a medication that is making their thinking worse for years, with the cognitive deterioration quietly blamed on the condition the medication is supposed to be helping. If that description sounds familiar in any way, it is an important pattern to name specifically in your next appointment. If this is helping you connect dots you have been trying to connect for a while, take a moment to hit the like button right now. It genuinely helps this information reach more people over 60 who need to hear it and who may have been writing off their cognitive changes as simply getting older, when the real cause may be a prescription they have been taking without question for years. Number 2 involves a class of medication that many of the people taking it do not even know they are taking, because these drugs were originally developed for something far more serious than the condition for which they are now being widely prescribed to older adults. Number 2 is antipsychotic medication, and this entry belongs at number 2, not because the medications are always prescribed inappropriately, but because the gap between how they are prescribed and what they actually do to the aging brain is one of the most serious and least discussed patient safety issues in elder care today. The names most commonly encountered are quetiapine, sold as Seroquel, risperidone, sold as Risperdal, and olanzapine, sold as Zyprexa. These medications were developed and licensed for serious psychiatric conditions, including schizophrenia and bipolar disorder, conditions involving genuine psychosis, where the risks of the medication are justified by the severity of what they treat. Over the past 2 decades, however, they have increasingly been prescribed off-label, meaning for conditions they were not specifically licensed for, to older adults who are experiencing sleep disruption, mild agitation, restlessness, confusion, or behavioral symptoms associated with early dementia. In some care settings, they are used primarily because they make distressed or confused older adults easier to manage, which is a use that most people, if they understood it, would find deeply uncomfortable. The cognitive cost in older adults is substantial and well documented. Research published in peer-reviewed journals following large cohorts of older adults prescribed antipsychotics for behavioral symptoms has found dramatically higher rates of cognitive decline over the following year compared with matched adults not on these medications, even among people with no prior diagnosis of dementia. The mechanism is not difficult to understand. Antipsychotics work primarily by suppressing dopamine, a neurotransmitter connected not just to mood and motivation, but to focus, executive function, planning, and memory. Suppress dopamine significantly in an aging brain, and the result is a brain that operates slower, with less initiative, with a flatter emotional range, and with a growing difficulty holding on to complex thoughts. Families watching someone they love on these medications describe the experience with language that has become heartbreakingly familiar to anyone who works in this field. They say their parent or their spouse seems absent, that they are physically present but somehow not there, that the personality has been blunted along with the agitation the medication was meant to address, that they are grieving someone who has not yet died. And in many cases, when these medications are carefully tapered and discontinued under medical supervision, something remarkable happens. The person comes back. Not completely, not always, but enough that the family recognizes them again. If you or a family member is taking an antipsychotic medication, the most important question to ask the prescribing doctor is a direct one. Why was this started? What specific condition is it treating? And is it still necessary at the current dose or at all? Many behavioral symptoms in older adults that are managed with antipsychotics respond equally well or better to non-pharmacological approaches, including consistent daily routines that reduce confusion and overstimulation, identifying and treating hidden physical pain that was driving agitation, improving sleep quality, and increasing meaningful daily activity. When medication is genuinely necessary, the lowest effective dose for the shortest possible duration dramatically limits the cognitive harm. And now we arrive at number 1, and I want to be clear that this is not a single medication. What I am placing at the top of this countdown is the pattern that ties every previous entry together, and it may be the single most preventable driver of medication-related cognitive decline affecting adults over 60 in this country today. Number 1 is anticholinergic burden, sometimes called polypharmacy-related cognitive decline, and understanding it is the most important thing you can take away from this video. Before I explain the mechanism, I want to say something directly to the family members watching this, because I know that many of you are here not for yourselves, but because someone you love has been changing in ways that frighten you. What I am about to describe is not a reassurance that everything will be fine. Some of the cognitive changes produced by medication burden are irreversible if caught too late, but many are not. And the earlier the question is asked and the earlier the medication review happens, the more recovery is available. If you have been watching someone you love decline and the explanation of simple aging has never quite felt complete to you, the information in this final entry may be why. Hold on to it and use it. Here is what this means and why it matters so much. Many older adults are not taking just one anticholinergic medication. They are taking several prescribed by different doctors for different conditions at different appointments, with no single prescriber having a complete picture of the total combined effect on the brain. Diphenhydramine for sleep from the drugstore, oxybutynin for bladder urgency from the urologist, paroxetine for anxiety from the primary care doctor, perhaps a bladder medication, an older antidepressant, an antihistamine, and a sleep aid all being taken simultaneously, each one exerting its own independent anticholinergic effect on the brain's acetylcholine system, and each one compounding the effects of the others. Individually, each of these medications might produce only a modest and barely noticeable cognitive effect, particularly at a standard dose. Together, their effects stack. The total anticholinergic load on the brain is not the sum of their individual impacts. In many cases, it is multiplicative. Researchers who study this have developed what they call the anticholinergic cognitive burden scale, a scoring system that assigns points to medications based on their individual anticholinergic strength. A person with a high cumulative score on this scale, meaning someone whose combined medications place a heavy total load on the brain's acetylcholine system, faces a cognitive risk that research has consistently found to be dramatic and in many cases permanent if the situation is not identified and addressed. I have had patients who came to me with cognitive assessments suggesting early dementia who were taking combinations of anticholinergic medications nobody had ever added up for them. We worked with their doctors to systematically reduce and, where possible, eliminate the highest burden medications, replacing them with safer alternatives or non-pharmacological approaches wherever that was medically appropriate. And in several of those patients, the cognitive recovery over the following months was dramatic enough that their families could barely believe it was the same person. Not complete recovery in every case, but meaningful, measurable, life-altering improvement in people who had been told they were simply aging and there was nothing to be done. The fix is not complicated, though it requires someone willing to do the work. It begins with a comprehensive medication review where every prescription medication, every over-the-counter product, and every supplement you take regularly is listed and assessed for its anticholinergic activity. Your doctor or your pharmacist can use existing scoring tools to calculate your total anticholinergic burden. Once the picture is clear, unnecessary or duplicative medications can be reduced or discontinued under supervised guidance. Safer alternatives that achieve the same therapeutic goal without the same anticholinergic load can be introduced. And the brain, given the right conditions and adequate time, can begin to recover function that many people had assumed was permanently gone. Here is the action I want you to take this week. Before your next medical appointment, write down every medication you take, including everything from the pharmacy shelf. Bring that list to your doctor and use this specific language. I have been reading about anticholinergic burden and cognitive risk in older adults. I would like to know if any of my current medications have significant anticholinergic activity and if the combination I am taking places me at elevated risk. That question, asked directly and specifically, opens a conversation that many doctors are genuinely glad to have, but that most patients never initiate. If your doctor is not familiar with the anticholinergic cognitive burden scale, that is not a criticism of them. It is a relatively new area of clinical focus, and the guidelines are still working their way into routine practice. But the information is real, the research is solid, and you are entitled to bring it to the conversation. I want to hear from you. Of the 5 medications and the pattern we discussed today, which ones are currently on your medication list? Have you noticed foggy thinking, word-finding difficulty, or memory slips since starting a new medication and simply assumed it was aging? Tell me in the comments below and tell me you will ask for a medication review before the end of this month. Your answer in those comments might be the very piece of information that reaches the next person reading them and prompts them to have a conversation that changes what happens to their brain. One important note before you go. Nothing in this video is a recommendation to stop any medication on your own. Every medication on this list was prescribed for a real reason, and stopping suddenly or without medical supervision can produce outcomes that are genuinely dangerous. What this video is a recommendation for is having an informed, specific, and direct conversation with your doctor about whether the cognitive risk of each medication you are taking is justified by its benefit in your particular case, and whether safer alternatives exist that achieve the same therapeutic goal. That conversation is one you have every right to initiate. And based on what the research says about how rarely it is initiated and how much difference it makes when it is, it may be the most important health conversation you have this year. If this video helped connect dots you have been trying to connect, please give it a like, subscribe if you are not already, and share it with someone over 60 whose memory changes you have been worried about. The chances are good that nobody in their life has ever framed this question for them the way we framed it today. The brain is more resilient than most people are ever told. But that resilience has limits. And one of those limits is how long it can tolerate a chemical burden that is working against it without intervention. The earlier the conversation happens, the more of that resilience is still available to work with.